Hi Shahir. Thank you. Okay, so I'm just gonna go ahead. It's 6 o'clock. So I'm just gonna continue from the last time. We're just gonna talk about the National Clinical Assessment today, part 2, about the remaining 6 OSCE stations. Uh, I think it's the holiday season, so people are quite busy, but it's okay. There will be a recording and I'll put it on the YouTube and send it out to you guys. So let's jump right into it. So in the last session in NCA 1, we did all the the first 6 OSCE stations. So in the NCA, there will be, as of 2022, there were 12 stations. So 2 of the stations were history taking. So we discussed about focus history taking. So there are 2 stations for this, usually in the exam. The second is an examination station, which you will see all your PPEs outside of the station. It's very clearly labeled. Then the third will be safe prescribing, where you'll be asked to look at the BNF, review prescription, or write a prescription, a simple FY1 level prescription, nothing high level. The fourth station would be recognition and management of an acute illness. So you'll be given probably one of the types would be an A to E assessment. Yeah. Then the fifth would be a surgical or perioperative care station, where a patient would ask you, they are due for surgery, and they have some questions about what their surgery entails. Nothing high level, simple surgery such as cholecystitis, appendectomy, and whatnot. So you just have to explain to them what is an appendectomy, answer any question that they have. Like they will ask you how big is the wound, is there other ways? Is it only an open surgical option, or there's keyhole, and somewhere along that line? Nothing too, they are not going to ask you about uh techniques of doing an appendectomy itself. So don't worry about that. And the last station that we talked about in the last session was discharge planning. So when the patient wants to go home, and you as a FY1, you are asked to go and talk to them and see how is their home conditions like, and do their discharge planning if they need any help, whether do you have to refer them to a dietitian and whatnot. So today we're going to talk about the remaining 6 stations. It's actually 5 stations, because as you can see in the focus history taking, there are 2 stations already. So there will be only 5 more themes that we will talk about today. So today's theme, we'll be talking about the teamwork OSCE station, challenging communication station, ethical and legal issue station, health promotion and patient education station, and last but not least, practical procedure station. Okay, so teamwork in the NHS in the UK, teamwork is very important, that you can demonstrate and understand what is teamwork and actually work together. As you can see, teamwork makes the dream work, obviously. And there are so many allied healthcare professionals. There are nurses, occupational therapists, discharge coordinators, physiotherapists, nurses, nursing aid, and so many doctors. So we must be able to work together so that we can provide the best patient care that we can. So in this station, there are 3 types of teamwork. There are three ways that teamwork can be assessed. One is a referral situation. The second would be a handover situation, and the third would be an ISPA, where you use the phone and you hand over to another colleague, whether a senior or a colleague of same level. So handover, how do they do it? I was in the exam, there was 2 A4 size patient cards. Usually around 2 to 3 patient cards will be given to you, and you have time to read it. Of course, not too long. There will be the basic patient information, like why the patient's here, how is he doing, and what's happened, and whatnot. Okay, and then the examiner will ask you, who do you prioritize first and why, obviously. So there could be a DKA patient and the sepsis patient. So based on the vitals that you see and based on your knowledge, you should be able to assess who needs a more prioritized treatment. Okay, you can also mention that you want to use the early warning score to stratify. I don't think you're expected to calculate the early warning score there and then, But if you can and you're confident that you are able to do it, that I'm sure that will impress the examiner. But it is not a must. It's not a need either. You can just say, I will want to do the early warning score. So read the vitals properly, read the history properly, and then explain clearly why do you prioritize this patient over this patient. Okay. Next is ISBA and referral. They are quite similar. So to do a referral, you should use the ISBA system. And to do a phone call, you can also use the ISBA system. So I think most of us who graduated from RCSI, we've been exposed to the ISBA system. So there are many ways of doing it. And there's not only the ISBA tool available out there. I'm sure there are many. If you look at Sharishka's video, actually, she has her own way of doing it. But since we are giving this talk targeted to our CSI students, I'm just going to use ISBA. And it's the one that I'm training, I'm most comfortable with. So ISBA just stands for Identify, Situation, Background, Assessment, and Recommendation. So when you make a phone call or when you actually see someone face to face in the OSCE station, you can use these two very quickly in your mind so that, and you just remember what to tell them, straight to the point, follow the mnemonic here. And then in this way, it's very safe that you wouldn't miss out anything. However, if you're not really used to using these two, I would recommend that you use something that you're comfortable, or if you choose to use these two, probably like practice it with someone so that you can do it very fast or very effectively, so that you don't fumble when you're there, because every station is only 9 minutes. Okay, so in Identify, you have to identify who you are. Common sense, when you pick up the phone to call a stranger, you always tell who you are, right? You wouldn't like just say hello, you would just say hello, my name is what. Same thing when you're calling a colleague or even a stranger, the MedReg on call, which most of us, I don't think we would know, like, because we are just calling the switchboard and the switchboard will give us who is on call. So you can identify yourself, say, Hi, my name is Dr. Abigail Tan. I'm from the surgical team. I'm the FY1 from the surgical team. I'm calling you regarding patient James Smith. He's 75 years old and he's in the surgical department. Can I talk to you about his problem and ask for advice? Then usually in the NCA exam, of course, they wouldn't make your life difficult. They'll say, yes, go on, sure. And then you can also say, but first, can I find out what is your name? Because I think it's respectful if you ask the person on the other side of the call, like what is their name, right? Secondly is situation. So the next thing is you can call, then you go, because as doctors, we have so limited time. So you want to jump straight at it. What's the situation now? Why are you calling him? You don't have to go around beating around the bush and telling all the unnecessary story. Just go. I'm calling about James Smith. He's 75 years old. He is deteriorated. We have given him this and this and this. His vital signs were X 2 hours ago. However, now it has dropped significantly. Give the values, okay? Give the vitals. If you have, even better, you can give a pattern of the early warning score. That would really help. Okay, background. So you can tell what the patient has. The patient is a patient of a COPD patient. Patient has pre-existing heart disease and whatnot, any allergies. Then the A is for assessment. What do you think the problem is? I've assessed this patient and I think the problem is the patient is going into DKA. Yep. So I have done this, but it is not working. I would like to ask for your advice and whatnot. Okay. And then it's very important that you state exactly what is the problem, like blatantly just state what is the problem, what you think the problem is. If you can, and if you're confident enough that you know the diagnosis, you can just say, I think the diagnosis for this patient is a DKA and whatnot. Okay, but make sure you state the reason and the problem very explicitly in assessment. Then go on, last but not least is recommendation. So you can ask, I'm sorry, but I've done all this already. Is there anything else you can recommend me to do? Or can I ask if you could come and have a look at this patient? But in the meantime, what would you like me to do while waiting? Yeah. So you can, the R also can stand for read back. Sometimes with you need someone, if it's a very important message, you can ask the other party to read back to you. The way you ask it is, I mean, the way you can ask it very in a non-insulting manner is you can say, I'm worried that I have left out something. It would be great if you can repeat what I just said to you. You see, then it doesn't feel like you are questioning if the person was listening to you or not. It's merely for patient safety purposes that both sides gets the right information. Okay, so this is a very good tool. It seems like a lot now if you're not used to this tool. Like I say, if you're going for the exam, just um, practice once or twice with your friends on using the ISBA, and you'll be able to use it quite easily when the exam comes. Yeah. So yeah, this is about ISBA, and because this is a NCA, it's just a FY1 level, everything will be given to you on the paper. You don't create new vitals, don't create new reasons, and don't create new diagnosis. Just read from the paper what has been given to you. Just regurgitate everything out in this manner, in the ISBA manner, and then that's your task. It's done. Yeah. So I have a scenario here, and I will just give you an example of how I would do this scenario. So you are in FY1 on the Ward 11. Jane Smith is a 70-year-old lady who was admitted with an infective exacerbation of COPD 2 days ago. She has a background of COPD, hypertension, and heart failure. For the past 2 days, she has responded well to IV co-amoxiclav. But now the nurse has rang you up saying that her vitals are 90/42, heart rate 130, respiratory rate 25, temperature is 38.7, saturation is 85% on 28% venturi mass, and her GCS has dropped to 13. So you have assessed her, you have prescribed her 2 IV fluid boluses, IV PCM, you've taken blood cultures, you have switched her antibiotic to piperacillin tazobactam, and you started her on 15-liter non-rebreather mask. Unfortunately, she's not responding, and her SATs is only at 91. So call for an advice from a relevant senior. So you see, this is the type of things that they would give you in the NCA exam. They will not give you anything for you to, like, because you only have 9 minutes, they will give you everything on the sheet of paper. So it's very clearly, I'm sure you can see that the vitals are given the whole story. You do understand that you can follow what's going on. It's not a very complex situation. So the task is for you to call for advice from a relevant senior. So in this case, you would call the med-reg. So yeah. So using the ISBA method, I've written down here introduction, situation. So I would say, hi, my name is Dr. Abigail. I'm one of the junior doctors on the Ward 11. May I know if you are the medical registrar? I was wondering if I could ask you for advice regarding a patient named Jane Smith, as she is very unwell. So from the start, you already said you are asking for advice about a patient named Jane Smith, and you're telling the other party that she's very unwell and you're not just calling them for fun, but you actually need advice. So next is situation. So the patient name is Jane Smith. She's a 70-year-old lady. She was admitted with infective exacerbation of COPD 2 days ago. She was stable for the past 2 days under IV co-amoxiclav. However, the nurse just informed me that her vitals dropped to BP 90/42, heart rate 130, respiratory rate 25, temperature 38.7, SATs is 85 on 28% venturi, and her GCS is 13. So as you can see, her vitals are very alarming. She is going into shock. She's approaching that. Her BP is dropped significantly. Her heart rate is very high. Her respiratory is definitely very high. She's having a fever for sure. And her SATs is 85, even on a 28% venturi, and her GCS is definitely low. The patient is very unwell at the moment. So you've given everything in just 3 sentences. So then you can tell the other party what's her background. So she has a background of COPD, hypertension, and heart failure. And then assessment, what you have done. So I have assessed her, and it's likely that she's having sepsis. So you see, you have in assessment, it is very important that you state what is the problem. What do you think is the problem, right? As an FY1, you also want to do your job to be able to assess her and suggest what is wrong. You don't want to just turn up in the hospital like, oh, I don't know what's happening. I just want seniors to help me. So you have to take charge of your own learning as well. Try your very best, assess her, and say, okay, she's having sepsis. Although this is only in an OSCE station, you're only given a piece of paper, but I'm sure from the original stem, from this stem, I'm pretty sure that you can make out that she's going into sepsis. So translate it into actually making the phone call. You can say, the diagnosis, I think she's having sepsis. Okay, so what have you done? So based on the paper that was given to you, you've started her on 2 IV fluid boluses. You've given her IV paracetamol. You've taken blood culture, switched her antibiotics, started her on 15 liters non-rebreather mask, this is all the part of the sepsis 6 bundle. You can say it as well. We started her on the sepsis 6 bundle if you don't want to say so much, but you should say it since it's already on the piece of paper that's given to you. And then unfortunately, she's not responding, and her current saturation is only at 91% on 15 liters, which is definitely not good as well. So based on this 1, 2, 3 sentences, I'm pretty sure the person on the other side of the phone call already knows that the patient is definitely not well at all. So 3 sentences, you've conveyed that the patient is definitely unwell and you need help. Okay, so the recommendation you can say is, I would like to ask if you could give me some recommendation or advice, or perhaps you could come and have a look at Jane. Then another thing I would recommend adding is, uh, if you're coming to have a look at Jane, is there anything you would like me to do in the meantime? Any other extra tests would you like me to investigate? So because sometimes the other party would not be able to come immediately to see the patient, but there are things that you can do, like send for a new blood, send for CRP, send for CSR and things like that. So that's about ISPA. ISPA usually, if you practice it well, it would not even take 7 or 8 minutes. The case given is simple, probably max 7 minutes you would take. It's one of the easier stations, I would say. So next, moving on to challenging communication station. So we have breaking bad news to the patient. There will be a patient, you will have to break the bad news to them. And very uncommonly, you might be asked to handle complaints. Okay, I'm just going to talk about breaking bad news because of the time constraint that we have. So here's the scenario that I have. So Mrs. Smith had an OGDS done about 2 weeks ago due to a long history of dysphagia and dyspepsia. So the result has come back and it shows that she has gastric cancer. Your task is to inform Mrs. Smith about the results. Okay, this is a very common OSCE breaking bad news scenario. It can be any cancer or whatnot. Okay, so the key of doing this is to be human and be able to empathize with them, right? Not just going, oh, I'm sorry, Mrs. Smith, you have cancer, and yeah, and then bombard them with a whole load of medical knowledge. Okay, in the NHS, they emphasize a lot on communicating, like be human, empathize, communicate with them properly. Okay, so I've put this on in a table. This is how I would do it, and this is what the dialogue that I would say. So I'm sure RCSI students, you guys are familiar with the spikes tool. Okay, you can look it up. Spikes just means for setting, perception, invitation, knowledge, emotions and empathy, strategy and summary. I love this tool very much. It again, like in a very difficult communication, having a mnemonic really helps you go through everything in a very systematic and orderly fashion. Okay. because breaking bad news is always hard when someone is crying or it is a bad news. So having something to guide you would make your life much easier in difficult situations like this. So going back to the scenario, so this is how I would do it. So first you open, you say you greet, of course you go through the normal formalities like, hi, Mrs. Smith, how are you doing today? So please come and have a seat in the, this would be in the clinic, that the patient would be with you. This would not be done over the phone. Okay, even the SP, the simulated patient, will be in the station with you. So then you would sit down, then you would just tell her, Mrs. Smith, we are in a private and confidential place. I've ensured that no one will interrupt us. Are you all right to proceed? And then she'll say, okay, yes. Then you ask them what is the perception of what has happened so far to them. So you will tell them, I've seen that you've done a biopsy 2 weeks ago via a camera test, which is an OGDS. Use layman terms. They will not know what an OGDS. Just say it's a camera test via your mouth. Okay. Then just double check, is this correct? Did they tell you what was it for? Can you tell me more about it? Did anyone tell you what's today's appointment all about? If you do this perception part well, you would save yourself so much time at the bottom, because you would already know what they already know, and you wouldn't repeat things that they already know, which eats up into your 9 minutes time. So get the perception right, ask them what they already know, and ask them if they're anticipating any bad news or good news, or they are like, I don't know, they just asked me to come for a camera test. I don't know what is it for. So you know how much bad news, like how are you going to break the bad news, you see. Next is invitation. So you want to invite them to know about the results. So you tell them, so I do have the results with me today, but first I would like to double check if you would like to have a friend or family with you today. Yeah, then you wait for them to reply. Then you ask them, you tell them, unfortunately, I have some unpleasant news to inform you. Then you could pause for a while. Pause is very important in doing breaking bad news. Then you can go on and say, is it all right for me to proceed? Then they would say, yeah, it is all right for you to proceed. Okay. Then next, knowledge is, now is the time for you to give them the knowledge of them having cancer. Okay. It doesn't mean you are going to blab and give them all the medical knowledge that they need now. So just say, I'm very sorry to tell you that the result says that you have gastric cancer. So take a pause. You should pause. I would definitely pause for quite some time, actually. Don't worry about eating into your time, because the SPs are trained. They are really, really good actors. They know when to, they wouldn't let the situation drag on for too long. Okay. So you just make sure you do the pause. It shows that you are empathetic, that you are giving them a very big news. Okay. Give them time to process the information. Then you could ask them, or is it all right for me to proceed? Would you like me to tell you more? Then they'll say, yes, you can proceed. Tell me more. What is it? What am I going to, what's the treatment like? Yeah. So again, remember, no jargon. Gastric, then you can tell them gastric cancer is the cancer of the stomach. Then you can say, usually based on your knowledge, you must give them the correct knowledge also. Based on what gastric cancer is the cancer of the stomach. Okay, so there are ways of treating it. Usually it's surgical treatment. We might also add some radio or chemotherapy. However, details of it we will have to discuss with the oncologist and see at what stage is the cancer is, and then we will move on from there. Okay. When you're giving the knowledge, especially in an exam setting, it's very easy that you dig your own hole and probably say something wrong, especially if it's something that you are not familiar with. Like gastric cancer is something at the current moment, at the top of my head, I don't know much about what is the treatment options. Okay, so try not to dig your own hole. Don't say too much, because the more wrong information you give, the more doesn't look good on you, and you might be marked down because of that. So you can just have a general idea what is it. Gastric cancer is surgical treatment, added on radio or chemo, okay? And then you can always just say, we'll need to discuss with the oncologist, we'll have to discuss with the surgeon first, and then we will move on from there, okay? And then next, you want to address the emotions and be empathetic to them. Then you can see, I can see this. Don't try not to say I understand, because they can always say, how can you understand me? I have cancer. Do you have cancer? That kind of thing. Just say, I can see that this is a very distressing news, and I'm sorry that I have to deliver it to you. Okay. Then you can ask, do you have any questions for me? Is there someone else that I can help to get you home and whatnot? Like, just be kind and ask them if there's anything else that you could do for them. Okay. Last but not least is strategy and summary. So how are you both, you and the patient, going to tackle this cancer problem now? So first step, it's good to give patient the time to process the information, because they might want to go home, tell their family, read up about it. Okay. So give them time and tell them we will meet again in a few days, and then we can go over the details of the treatment. We can get the surgeon and the oncologist involved then in the meeting. Okay, and then you can offer them some leaflet. Whether you actually have the leaflet in the station or not doesn't matter. All you have to do is just say it. I'll give you some leaflet. We'll print out some leaflet. You can take it home, have a read about it. Okay. If you need any help, call the clinic. We will give you the clinic number as well, and we'll be here to help you. Okay. Just give them leaflets. These are like value added points, Okay. So yeah, you need any help at all, do call the clinic. We will be here to help you. Okay. Then you can say thank you for coming. I hope you're okay. And then you can just close the conversation and just go on. Okay. Again, bringing bad news is something you have to practice like 2 to 3 times. Get someone with you, or best, get someone to practice with you, and see what your friend comments about it. Okay. Yeah. On Geeky Quiz, I mentioned it about this website. It's under Geeky Medics, but Geeky Quiz is a paid one. There are a lot of OSCE stations, so they do have a few. They have Breaking Bad News 1 and Breaking Bad News 2. So you can go through the OSCE station, practice the OSCE station. There's a marking scheme, so you and a friend can get it done. Just practice. I use the Spikes tool a lot, but if you are familiar with other tools, you can go ahead and use. There are no specific tools for the NCA itself. So handling complaints, I'm not going to dwell into this due to time constraint, but I found that this YouTube is really good. The patient was a very difficult one. So you learn from the doctor how he manages complaints. This is about medication error, actually. So 9, the next station is about ethical and legal issues. So 3 things that can be tested in this station is a DNAR station, or mental capacity assessment station, or a mental health X station. Okay. I've attached here the video to Shariska Singh's video. You must look at it. She's really, really good. She's done a lot of work in NCA, so she knows very well. So DNAR. So do not attempt resuscitation. This is something that they test a lot in the NCA. So ideally, a DNAR should be, in an ideal world, the clinician agrees for it, and the patient also agree that they should not have a resuscitation. So this is what we want, actually. But sometimes the patient wants it themselves, but sometimes the clinician decides and informs the patient. Even the patient doesn't want it. So in the UK, apparently the physician actually has the power to do it. Okay. Do check out this website, the NHS. This has much more much more information about DNAR. Okay. Yeah. So extra information is families can actually deny treatment, but they cannot demand for treatment. So if the patient the patient cannot demand that the doctors start giving resuscitation, even though it's been, yeah, when the DNR has been signed, they cannot demand for it. Okay, so as you can see, the ultimate decision lies with the clinician. So even if the patient doesn't want it, the clinician has the power to decide, because they are the healthcare team. So ideally, we want the patient and the clinician to agree. So this is why our job is very important. This station is very important, actually, so that you can talk to the patient, get them to understand what's happening with them and why a resuscitation is not the best thing for them. Okay. So in a nutshell, DNAR is solely a DNAR order is solely regarding the CPR in the event the heart or lungs stop by themselves, obviously. But it doesn't mean, once you sign the DNR, it doesn't mean we will stop treating or giving medicines to the patient to treat their current illnesses. Okay. Always say this in this station, because when the SPs are trained, they will always say, oh no, if I sign this, you guys are going to stop treating me. So that is not the case. A DNAR does not work that way. A DNAR just solely means that in the event the heart or lungs stop, CPR will not be given. That's about it. Okay. It doesn't mean that once you sign that we will immediately withdraw treatment for, okay, let's say end stage heart failure. Okay. It doesn't mean that once you sign it, we will stop all the furosemide and painkillers and whatnot. Okay. So a lot of patients, they are very scared to sign a DNR, or even their families, is because they think a DNR means that we are stopping the treatment and we are just letting them die. That's not it. It's just regarding CPR in the event the heart or lung stop. So this is important. You can get more information in this link at the bottom here. It's very important. Read that. That's the NHS website. Okay. Yeah. So this is the website. So it has laid out in layman terms. So you can literally just read this and then regurgitate it in the OSCE station, because this website has been written in layman language. So just have a read. It's very good. Okay, so we just have a DNAR scenario. So Jane Smith is a 90-year-old lady with multiple comorbidities. In this admission, she presents with decompensated heart failure, and despite maximum treatment, she's not responding well. Her family wants everything to be done for her, including resuscitation. Speak to the appropriate person regarding DNAR. So usually you will be asked to speak to Jane. Okay. So the way of doing it, Sharishka Singh also has a video that's really, really good. You should definitely look into it. Okay. Yeah. So the way I would approach this station, if I'm asked to speak to Jane Smith, is, so you will just go in the room, like this, knock and say, "Good morning, Jane. How are you feeling today?" And then she will reply you, "Oh, I've seen better days," and whatnot. Okay. Then you introduce yourself. "My name is Dr. Abigail, and I'm sorry that you have been feeling better in other days. Well, I need to have a little chat with you about your long-term care." Okay. Then they will reply you. Then you can say, you can also say, "Have you thought about what will happen to you in the long run?" And she'll say, "What do you mean? Like, why are you talking about this?" Then you can just say, then you can this is the chance to slowly ease into it and explain to her situation, which is in this scenario. So you have to tell, "Hi, Margaret, I mean that Margaret, Jane, you are already 90 years old and you have a lot of other diseases around you. And in this admission, you have heart failure, which is not responding to any treatment that we are doing, right? That's why you are not feeling as well as before, because your body is not responding to any of the medication or the treatment that we are trying to give you." Then you can go right at it and ask her, "Have you ever thought about, in the event of your heart and lungs stop, what would you like to be done?" Yeah, it's a very easy, like a good way. Sharishka does it in this manner, like how to ease into it. So yeah, so you can ask her, in the event of that your heart and lungs stop. Have you ever thought what would happen to you? Yeah, then the SP will give you their thoughts. Don't worry, it's not going to be a complicated DNA situation. It will be something that is easy for an FY1. Okay. Then you can say, have you ever heard about CPR? Then they'll tell you, yes, I've seen it on TVs and whatnot. Then you can tell, I'm here to actually talk to you about what we call a do not attempt resuscitation order. So this means that in the event your heart and lungs stop working, okay, we will not give you resuscitation, which means CPR. Okay, say it slowly, say it in a simple sentence so that they can understand. Okay, and then normally the SP will say, no, I don't want it. This means that you will withdraw treatment for me and you're just going to leave me to die. Then this is a time where you can correct their understanding and say, no, it doesn't mean that we will stop treating you now. It just means that in the event your heart or your lungs stop beating and stop breathing on its own, we will not do CPR. Okay, CPR is a very traumatic thing to be done to your body. So we will have to put in a lot of big tubes and needles into your arms and veins. Then you need to have tubes down your throat. Then someone will be on your chest, pressing it very hard. Ribs can break. It is very, very unpleasant and very traumatic. And our team has decided that given your age, your frailty, and with the heart failure that hasn't been responding, we think the best thing to do is to have a DNAR, because we do not want to we do not want to further cause more trauma to your body. Yeah. Then you see, it's an easy way to ease into it. Okay, then she'll be like, okay, but what if I have so much more to live with? Then you have to explain to her again that we are not withdrawing treatment. We are just planning ahead in the event your heart and lungs stop. We will not attempt CPR. That's it. Okay. If you at the current moment, any treatment, even if you sign the DNAR today, any treatment that you need will be given to you accordingly. Okay, will be continued to be given to you. It doesn't mean that once you sign, we are just gonna go. Okay. Then Sharishka did say sometimes they might ask, so what are the odds of me what are the odds of me surviving through this CPR if you do it? Okay, so sometimes the patient, the SP, might ask, what are the odds of me? What if you do the CPR? Don't I have a chance to come back, be alive again? Right? You can just say, of course, there will be a chance that you can survive, but she did say, like, you can say it in this way, where even in a world-class athlete, CPR does not work 100% of the time. Okay, even in an Olympian athlete, CPR does not work 100% of the time. So, and put you side by side with an world-class athlete with your heart failure, I don't think the odds are very well. That's why we want to speak to you today. Okay, then just go on. And then last but not least, I would always close the OSCE station by saying, I just want to reiterate that we are not stopping treatment for your heart failure. We will give you all the necessary medications that you need for your pain and your heart failure. It's just that in the event your heart and lungs stops by itself, we will not do CPR, which is a very traumatic thing for your body. Yeah. So then you can say thank you and then give her some time. We'll give you some time to think about it. Let me know if you have any more questions. I'm just outside the door. You can speak to me or any colleague. Yeah. Once you've done that, if you have time, turn to the examiner and say, I want to document what I've done. I've spoken. I want to document in the notes. I've spoken to Jane Smith about DNAR, and then write down what are the details that you spoke with her, the points. And it's very important that you document that you've spoken to her and what if she's made a decision or not. Okay. So this is a nice way. Do look at the Sharishka's video. She's really good. Next is Mental Capacity Act. Okay. This is not a difficult station, but you must just understand these 4 things. So this is the full definition of what the Mental Capacity Act is. You can read this in Sharishka's guidebook or on the internet. So very simple, just 4 things. The patient must be able to understand what you are trying to say, right? They must be able to retain what you just said, and they must be able to weigh and make a decision based on what you just told them, and they must be able to communicate back, whether written or verbally, what is their decision. So you just have to remember these 4 points, and you must, in your OSCE, when you are doing the assessment, you must demonstrate each of the 4 points that you have assessed, each 4 points adequately in the OSCE station in the 9 minutes. It's not a difficult station. You just need some practice. Okay, so to make things easier, I'll give you guys a scenario again. You are in the ED. Go speak to Mr. James, who has an episode of hematemesis and fainting. Earlier, your consultant has gotten consent for an urgent OGDS. However, now, Mr. James is refusing OGDS and he wants to go home desperately. Speak with him and assess his mental capacity. So in this OSCE station, there will be an actual simulated patient there where you will be talking to them. They are just lay people. They are trained actors, obviously. So you go and introduce yourself. Hi, Mr. James. I'm Dr. Abigail Tan. I'm one of the founding FY1 doctors on the ED team. So today I've been asked to talk to you. Is this okay? What's your name? You can assess PPT, person, place, and time. Do you know where you are now? Do you know roughly what time is it now? What time of day is it now? Then usually in NCA, it's very obvious that they do not have mental capacity, or even they might even have capacity. So, but it will be very obvious. It won't be something very vague because it's just an FY1 level. So they will say like, oh, yeah, I'm James. I'm in the zoo. I think it's midnight now. Yeah. So it's so obvious, right? But you cannot just say based on that, oh no, he doesn't have capacity. You must demonstrate each one of these, that you must demonstrate to the examiner each and every one of these. Then you make a decision. Okay. Then you ask him, do you know what you're here for? Then they'll tell you, yeah, I vomited blood. Then you said we need to do a camera test that we're going to put down your throat to look at what's happening. Why are you vomiting blood and whatnot? Then he'll be like looking at you blankly. Then you will ask him, do you get what I'm saying? Then he will look at you like, what? Like what? Then you can repeat your sentences again, explain and explain to demonstrate that the patient does not understand you, right? Then next is retain. If you have to repeat yourself 5 times saying the same information, obviously you cannot retain, right? So you've demonstrated that. Next, then you will tell them, so Mr. James, so you've been vomiting blood and you fainted, and we need to do a camera test. If you don't do the camera test, you could bleed out even more. You might go into, you might pass on and whatnot. Okay, but if you do the camera test, we will be able to see what's happening inside. Where's the bleeding? We can treat you for it, and you'll be treated for it. So, do you understand what's happening? Right? Then they might say, oh no, I just want to go home. So then you can repeat yourself again, repeat the same thing that you just said 3 to 4 times. And then obviously they do not understand the risks and the benefits of doing an OGDS, and they cannot weigh and make a decision. Okay, so you've demonstrated that they cannot make a decision and they cannot weigh the risk of going home versus the benefit of doing an OGTS. So you've demonstrated the third point. Okay, and obviously he the he cannot make a decision, so he can't communicate with you, or he's saying, I want to go home, I want to go home. Okay, so then you can say to the patient, okay, Mr. James, just give me a moment. I'll need to speak to my consultant. Thank you. Then you will speak with the examiner. Then the examiner will ask you, what would you do next if he has capacity? So obviously in this case, if he has capacity, if you assess all the 4 points and he has capacity, he can go home. He has the right to go home. But you must say, I will, if he has capacity, the patient is allowed to go home despite against medical advice. I will get him to sign a against medical advice form. I will document it in his file. I'll get a senior to double check with the patient as well that he has capacity. Yeah. So this is what you would say, the 3 things. Patient has capacity. I'll involve a senior. I'll document it in his file and I'll ask him to sign the against medical advice paper. Okay, these are the 3 things. So the next question the examiner might ask you is, what if he has no capacity? Okay, if he has no capacity, then you will say the patient do not have capacity. He has to be kept in hospital, and the OGDS will go ahead with it. Again, I will involve a senior. I will document it in the notes and get my senior involved. Yeah. Then the third question they could ask you is, can this mental capacity assessment be applied to other procedures? The answer is no, because capacity can fluctuate. Like the patient, if the patient has been losing a lot of blood, like their BP is very low, the capacity is affected. But what if after we've treated him, his blood level, his hemoglobin is getting better, capacity could be restored. So this mental capacity is only applicable to the OGDS. So the answer is no. Okay. So of utmost importance, always say in either way, capacity or no capacity, always say you will document everything in the notes. I will involve my senior. And then if the patient wants to leave against medical advice, I will get him to sign a form that is against medical advice form. So this is very important. Mental Health Act, not so common. Sample scenario would be Jessica is a 25-year-old university student who has been admitted to the ED for an episode of self-harm. She has a history of depression. She begins screaming that she wants to be discharged so she can kill herself at home again. Okay, speak with Jessica. So this is a example of a Mental Health Act scenario. So Sarishka Singh has done a very good role play with this, so you can have a look at the YouTube on her channel. We are running out a bit of time. I will not go on this. The next station would be health promotion and patient education. So there are 3 things that they can test: quit smoking, alcohol, quit alcohol, and obesity. Okay, so I'm just going to talk about quit smoking because this is the more common ones. Quitting alcohol, you can have a look at Geeky Medics. They have very good notes about quitting alcohol. So quit smoking. I'm sure most of us did this in psychiatry or GP, I can't remember. But this is how I would do a quit smoking, smoking cessation station. In 9 minutes, this is what I would do. Introduce yourself, of course. Ask them, do you know why you're here today? Or thank you for coming to the clinic today. Or so I've been asked to talk to you about your smoking. Is this okay? Yeah. Then you can ask them about their ideas, concerns, and expectation. What is your idea about quitting smoking? Do you have any concerns about quitting smoking at all? They might be concerned about the withdrawal symptom, so that's what that's stopping them from quitting smoking. Then ask them about expectation. So in today's consultation, what would you like me to be of most help to you? Yeah, that's the way you ask for expectations. Then take a very brief smoking history very quickly. I have some notes on the next slide. And then how to quit, give them, I use the STAR method a lot. It's short, it's simple, and it's sweet. So set a quit date, like 2 weeks from now, we will set 1st of January, set a quit date. Star T, ask them to tell family and friends so that once your family and friends know, they will not offer you a cigarette or they'll be more supportive and they're like, okay, you're quitting smoking. I'm not going to interfere with you. A, anticipate challenges, be realistic, tell them there will be challenges. It's not an easy, quitting smoking is difficult. So tell them to anticipate challenges. And R, remove any tobacco products from their home. This would make things a little bit easier, but it's still difficult. So the STAR method is quite good. Then the fifth, you can go into the medication and non-medication options of helping them. So you tell them what are the options. Sometimes many patients doesn't know, like they do not know what are the options that are available to help them to quit smoking. So you can say we have some medication pharmacological options. I think pharmacological can be replaced with a more layman term, but offhand I can't think of another word. You can look it up. So first we have nicotine replacement, patches and spray, as you see in the pharmacies and whatnot. Then we have another thing called bupropion, and then we have this varenicline. Geeky Medics gives more information about this. You can have a look. Then you can say, but we also have some other non-pharmacological therapies like counseling, which they will help you uh, teach you more on how to manage the stress and the challenges that comes with quitting smoking. And then tell them we'll have a follow-up schedule, a follow-up protocol, which is 1 to 2 weeks after your quit date, you'll come back, we'll have a chat. Then 4 weeks after your quit date, we'll have another chat. 3 months, and then 1 year, we'll come back and see. Okay, so this is a very good sample structure that I follow. You can do it in 9 minutes, actually. Just practice, you can do it in 9 minutes. So smoking history, very quickly, how long the patient has been smoking, how much, what type, tobacco, nicotine, vape, what situation. They can say, oh, I usually smoke only socially at work because everyone smokes, right? And then ask them, does smoking affect your relationship with your wife, with your children? Okay, and then how does the patient finance their smoking habit, because smoking is expensive? And then did the patient try to quit previously? What happened? Then you can, once you ask them this question, you can know what has happened in the past, and you can just target the consultation to helping them overcome specifically that stumbling issue that caused them to stumble the last time. Okay, and then ask them, why did you relapse? But obviously not in a judgmental manner, like just I'm so sorry to hear that, but can I ask, like, what happened? What was the most challenging thing you found? Why did like how why was it, yeah, like how, ask why it happened, like how come, what made you relapse, that kind of thing. Just watch your tone of voice and your facial expression, and then ask, do they have any withdrawal symptoms after stopping smoking for like have you ever tried quitting and then you have like shaking and sweating and agitation and what? So if they have withdrawal symptoms, there are things that you can give them to help with the withdrawal symptom. Last but not least, practical procedures. So normally there will be only one station that you'll be asked to do any of these procedures. So these are the things that I got from the NCA handbook. Very common final year or ski syllabus exam. Suturing, to be honest, rarely comes out, but I'm not saying that it won't come out, but just watch out that, just be aware that it might come out since it's in the NCA handbook. So PFR is quite common. Spacer education is also important. A rectal exam is important. Yeah, basically at least once run through all of this, practice once, at least a few times, make sure you know how to do it, because you have 9 minutes to do it only. So as you all should know, I think Geeky Medics is very good. Yeah, Google Geeky Medics blood taking, practice it. Yeah. Another thing I would highly recommend, this is what I did. I recorded myself doing the procedures at home, and then I would re-look at the videos and try to pinpoint what I did wrong, what I would like to improve and whatnot. So because I was alone, I was studying during the like COVID period, and none of my friends were taking this exam, so I had to do it alone. So studying it alone is not an excuse to not be able to do the exam. So there's always ways to do it. So yeah, I would recommend recording yourself, like scrutinize what is your technique like, and you will improve a lot. So yeah, I think this is all. If you have any question, just drop it in the YouTube channel and I will try to answer. Yes. Okay, thank you very much.